Good afternoon, ladies and gentlemen. My name is Michael Schenkel, and I am the Director of Capacity Building with HealthHIV, a national nonprofit based in Washington, D.C. And I'd like to thank you for joining our first 3D HIV prevention webinar series. This webinar series is on health insurance contracting for HIV prevention services, from barriers to billing. I want to provide you with a little bit of background about HealthHIV. As I said, HealthHIV is a national nonprofit based in Washington, D.C. We have four main capacities in our organization. Capacity building services that we offer to aid service organizations, community-based organizations, health departments, and community health centers around the country. We also have a health services research and evaluation function supporting evaluation and research capacity for organizations around the country, an education and training center, as well as an advocacy platform. HealthHIV has a number of key initiatives, including our Health HCV initiative, focusing on on HCV advocacy and education, a Positively Healthy National Coalition advocating for HIV-positive communities, which is made up of HIV-positive persons as well as their allies. A fiscal health program working with Ryan White providers in strengthening their fiscal sustainability of their HIV programming, as well as our Remaining Relevant in the New Reality series, an in-person activity dedicated to building the capacities of ASOs and CBOs in this changing changing healthcare landscape. Additionally, HealthHIV also operates the National Coalition for LGBT Health, which you'll hear a little bit about in a little bit. Also, our Health HIV capacity building programs, we provide a variety of capacity building programs to not only ASOs and CBOs, but to health departments, enhancing the clinical workforce capacity, as well as working with ASOs and CBOs to increase their technical capacity through our 3D HIV prevention programming. So why 3D HIV prevention? HealthHIV launched the 3D HIV prevention program in September of this past year, and the focus of the program is really to enhance the availability of technical assistance to conduct enhanced data collection and analysis to make better informed programmatic decisions that impact the delivery of quality HIV services around the country. Our approach of the 3D program is really to facilitate community infrastructure and development and systems coordination, to promote workforce development, including the training of the next generation of leaders in HIV prevention, expand care teams and care team integration through partnership development to include non-clinical HIV prevention partners, and to demonstrate the cost effectiveness and outcome monitoring of programs to maximize strength and efficiencies and impact health outcomes. We have a number of content areas which are also available on our website for you to peruse and examine. I do want to bring your attention to two programs prior to the initiation of this webinar. HealthHIV has launched an ASO CBO Leadership Training and Certificate Program. This is a program, a comprehensive program that is self-paced and provides an online curriculum in which individuals can take at their leisure. It is a 6-part audio and PowerPoint presentation with downloadable tools and resources for participants. It also offers a certificate of proficiency in ASO CBO leadership and provides links to ASO and CBO leaders to one another upon completion of the online program. The program currently has 4 modules, starting with planning, strategic planning, moving that to business planning, how to lead through changing times, basics on biomedical and strategic advances in HIV prevention, as well as the shifting funding priorities and best practices of organizations. We also focus on Medicaid and healthcare exchanges and assessing partnerships, mergers, and acquisitions of organizations. All of our programming through HealthHIV is currently a free service that is provided to organizations that are either HRSA or CDC funded. We also offer fee-for-service to organizations that fall outside of that parameter. In order to access the ASO CBO Leadership Training and Certificate Program, you may use the link on your screen right now. I've truncated that link for you so that you can easily write that down and access that for you today. I'd also want to just make you aware of 2 upcoming webinars that are going to be occurring later this month. The first of our Leadership Link and Learn Lunchtime series is focusing on what is leadership in healthcare today. And Dr. David Williams will be presenting that 45-minute discussion on March 18th. Feel free to register for that activity, as well as the National Coalition for LGBT Health in preparation during National LGBT Health Week. We'll be hosting a webinar on Wednesday, March 25th, Time for Trusting Relationships, LGBT Health Awareness Week, and we encourage you to also participate in that program as well. As we conclude today, we want to remind you to please complete the evaluation that you will be presented with at the end of this webinar. It's very important for us to receive your feedback on the delivery of our services for our continuous quality improvement processes. Additionally, if you need additional services, HealthHIV's capacity building programs can provide you with those services or to direct you to the services that are most appropriate for you and your organization. You can contact Marissa Tonelli, the Senior Capacity Building Manager with HealthHIV at marissa@healthhiv.org. During today's webinar, all lines will be muted, and you can feel free to use the text box, the chat box to the right of your screen to enter any questions that you may have during the presentation. We will also have a question and answer series at the end of today's webinar for Dr. Hidalgo to answer specific questions that you may have about the presentation, and that can either be done through the web link, writing your question in the chat box, or we can make a live connection to you simply by raising your hand. And we'll review that at the end of the webinar as we move forward. These slides will be made available after the presentation concludes today on HealthHIV's website. Also, there is a guide that is accompanying this website, webinar, which I will place in the chat box for individuals to be able to download that as we move forward. At this time, I'd like to turn it over to Marissa Tonelli, our Senior Capacity Building Manager, who will introduce today's presentation.
Good morning and good afternoon, everyone. I just want to introduce our speaker, our faculty member today, Dr. Julia Hidalgo, who will be speaking about health insurance contracting for HIV prevention services. She is a nationally recognized expert in HIV program design, financing, and evaluation, and currently serves as a research professor at the George Washington University, where she is the director of the HIV Care Collaborative National Program Office, as well as the co-principal investigator of the CMS-funded Prevention at Home project. Dr. Hidalgo also serves as CEO of Positive Outcomes, Inc., and she has worked for almost 30 years as an HIV policymaker, consultant, TA provider, trainer, and evaluator. She has collaborated throughout those years with federal funders, state Medicaid programs, planning councils, HIV prevention and care providers, and others to redesign and engineer HIV prevention, service, and financing systems. She has served as a consultant to state Medicaid programs throughout the U.S. to design and finance innovative HIV care and prevention programs, and she is here with us today to talk specifically about contracting for HIV prevention services. So with that, I would love to welcome Dr. Julia Hidalgo.
Good morning and good afternoon, everybody. I'm so excited that so many of you are on the line. So far, we have over 300 participants, which I think really underscores the interest in the prevention community to move from grant funding to third-party reimbursement. And so let's get started. Next slide, please. Just real quickly, and I'm going to move through many of these slides pretty quickly. As Michael has mentioned, we have some very detailed contracting guides and other materials we'll talk about in a little while that really will provide you a lot more detail than we can offer today on our presentation. But the way we've designed this webinar is really to increase the focus and knowledge of community-based organizations, health departments, and other folks that are interested in continuing to provide HIV prevention services across the country, particularly to members of the ACA qualified health plans, other commercial health insurers, as well as Medicaid programs. We're really interested in expanding your awareness of what can be provided through payment by third-party insurance payers, including the ones I've just mentioned. We also want to offer some caveats in terms of potential barriers you need to be aware of as you're moving forward in this domain. And then also to offer really practical strategies for advocating for payment for HIV prevention services. One of the things we're hoping to achieve through this call and other efforts is really to expand the dialogue among HIV prevention providers as well as CDC grantees and their funders, CDC, HRSA, as well as CMS, around the areas that we need to improve on in covering HIV prevention services in the health insurance system. And at the end, we're going to open it up and hope to hear from peers that are on the line that can talk to us about some of their experiences in trying to move forward in getting compensated for prevention. Next, please. So specifically what we're going to talk about today is an overview of the HIV prevention services that can be offered to health insurers. I want to make sure we're all on the same wavelength in terms of a basic understanding for commercial and Medicaid programs, facts and fictions, to make sure that we all understand how they actually pay for services. I'm going to talk about new emerging contracting opportunities for prevention providers, specific steps for contracting, what sorts of ways you can get paid for your services, and how you might deliver your services in a way to minimize your expenses. And then I'm going to offer some real-world examples of contracting opportunities. And then we'll end by offering some next steps for prevention programs to launch their contracting efforts. Next, please. So I'm going to go over two slides very, very quickly. I think that most of you are probably pretty committed to actually moving forward in terms of seeking payment for your prevention programs. But for those of you who are still on the fence or are really doubtful about opportunities, I want to just review why you need to start thinking about participating in health insurance. First of all, I think many of you recognize that most of our HIV positive or at-risk clients that are being served in prevention and care systems are moving into health insurance systems. We also need to think about new opportunities and new populations that you might be able to provide your services to. Those may be folks that are actually enrolled in insurance that are not actually able to obtain community-based prevention services through their health insurance plan. We want to make sure that as folks insure themselves through their qualified health plans of the ACA or other mechanisms, that they continue to have access to HIV prevention services and really make sure that we can address stigma and other barriers to prevention services. Many of you may need to think about new product lines that could include new prevention services or other services that you may not have thought of yet. And then it's also always important to diversify our funding sources so we're not dependent just on grant funds. Next, please. Additionally, prevention services funded through health insurers should be generated some discretionary income for your organization that will help you to pay for things that grants just won't cover. Now, of course, HAB, the HIV/AIDS Bureau at HRSA, and CDC have moved forward very quickly in requiring that their grantees and contractors start seeking, if they haven't already, health insurance funds to pay for what was commonly funded under grant funding. It's also important to recognize that as you're moving forward and formalizing some of your infrastructure, such as your accounting system, your agency is going to experience some really positive spillover benefits. And then finally, we're hoping that you'll make some money from these efforts and that you'll be able to cover your costs plus a little bit more. Next, please. Now, I just want to review real quickly what possible areas of HIV prevention services should be offered and how they really nestle in currently under CDC and HAB funding. And as you can see here, the whole array of high-impact prevention services are opportunities to be seeking compensation. And we'll talk about the infrastructure and the advocacy and marketing that you're going to need to undergo. But there, as you can see here, are some very specific services, some of which are already very often covered by health insurance plans, and then others such as PrEP and PEP and the wraparound services around those, as well as behavioral risk reduction services that are really pushing the envelope in terms of new opportunities for health insurance plans to actually provide and cover cutting-edge HIV, STD, Hep C, and other preventive services. HAB also provides a limited array of services under their early intervention services funding, commonly through Part A, Part B, and Part C. And in addition to the ones that are listed here, there are a whole array of secondary prevention services that are being offered. Now, both CDC and HAB also fund linkage, engagement, retention, relocation, re-engagement services, patient navigation, and a whole array of other services that are really in the interest of health insurance plans to pay for. And we'll talk about mechanisms to do that in a few minutes. Next, please. Now, I want to just talk briefly about the fundamental information that you need to know about commercial health insurance basics. As you can see here from the slide, we did an earlier in-depth webinar in the fall specifically around commercial health insurance basics for HIV prevention programs. If you didn't have an opportunity to listen to that, it's posted on the EPR website, and I'm hoping that you'll take an opportunity to listen to it because I won't be able to cover all the materials today. Next, please. Now, just to put a fine point on why commercial insurance should be of interest to you and your organization, as you can see here, hopefully, in the blue bars, as hopefully you can see, more and more folks are in fact entering and participating in private insurance across the country, those individuals, particularly young adults through middle age. And we're seeing that with the advent of the Affordable Care Act and enrollment in qualified health plans, the actual number of folks that are enrolled in those plans are increasing with every year. And I can tell you that I see many, many folks now with HIV, as I do chart review across the country, that are in fact eligible for or enrolled in private insurance. And so it's important to understand that this will be a really critical source of our marketing opportunities for prevention providers. Next, please. Now, just basically, commercial insurance models really are divided into two overarching groups. Group plans that are often offered through employer-sponsored plans. That's the way that many of us that are on the phone today are actually insured. We may be getting employment-sponsored plans through our employers, through our spouses' employers, our parents' employers, and so on. Also, the Affordable Care Act SHOP plans are for small businesses, and that is an increasing opportunity for HIV-infected or at-risk individuals to obtain insurance if they work for small businesses. Some, not a huge number, but some at-risk or HIV-infected folks also get their insurance through trade associations or professional plans. Think AARP's health insurance plan, for example. Also, there are individuals and families who self-insure, who directly purchase insurance through an insurance broker, and often will be able to get their insurance through that mechanism. And then I hope, as you all should know, the ACA marketplace or exchange individual plans also offer a tremendous opportunity for individuals, single individuals, as well as families to participate in health insurance. Next, please. Now, just for those of you who may not have thought about how your health insurer organizes their services and their payments, but essentially the health insurance plan is responsible for organizing a whole set of service providers that will actually be undertaking the services on their behalf through contract, or as in the case of a place like Kaiser, they are directly employing healthcare providers to offer those services. And as you can see here, hopefully, there's a whole array of services that health plans have to think about and arrange prior to undertaking each benefit year. Those services include the usual ones that we think about, and increasingly they're including community-based organizations, public health departments, and other sorts of providers to cover all the communities for which they've taken on responsibility. Next, please. Now, with the Affordable Care Act, there's some things I want to highlight in the commercial market. First of all, the ACA requires what are called essential health benefits. And for all the new marketplace plans, as well as for existing health plans, increasingly they're required to offer these essential health benefits. At the bottom of the screen, you can see that they are required to provide what's called preventive and wellness services, as well as chronic disease management. And basically, chronic disease management looks a lot like what we do in HIV related to medical case management. Next, please. The ACA also requires qualified health plans, as well as increasingly existing plans, to offer a service provider network that includes essential community providers. And I arrayed those here. And for those of you who are receiving Ryan White funded service, Ryan White funds, you would be considered an essential community provider, as well as if you're an STD clinic or TB clinic, for example, at a health department, or other agencies that serve low-income and medically underserved individuals. You can apply to participate as an essential community provider, and each plan has to identify at the beginning of the year to their marketplace or their exchange which essential community providers are in their networks. Next, please. Also, the ACA requires a whole array of preventive services be offered either as a requirement or optionally based on the grade that the Prevention Services Task Force has awarded it. As you can see here, HIV infection screening is required to be offered by the qualified health plans, as well as with an A grade, as well as an A grade assigned to syphilis screening for pregnant women and other individuals that are at increased risk for infection. B grades, as you can see here, have been assigned to chlamydia and STI counseling. And once again, it's really based on identification of the risk that individuals in those categories may present to their healthcare provider. So an A grade for HIV infection requires then that HIV screening be offered to individuals that are participating in qualified health plans. Next, please. Now, just to put a fine point on this and kind of translate this into your interests, it's important to note that there are ways that health insurers think that may be a little bit different from the way the rest of us in the world think about things. First of all, health insurers have to identify their enrolled members to offer them preventive or other services. Where we come in handy is that as HIV prevention and care providers, we're experienced and can demonstrate our track record in outreach, counseling, linkage to care, and patient navigation. As you can see from the slide, there are other opportunities that address the interests of health insurers. And I'm not going to linger on this slide too long, but I would like for you to come back to it and think about ways that you might be able as a provider to actually fulfill the requirements and the needs of health insurers in meeting these requirements. Next, please. Now let's segue over to state Medicaid programs. Once again, in the fall, we also offered a very in-depth webinar on state Medicaid programs for HIV prevention providers. And so I'm going to just talk about the highlights of that session. Next, please. So for those of you who have not been enrolled in or participating as a provider in Medicaid, let's just do a quick review. First of all, Medicaid is a state and federal entitlement program. In other words, if you meet the eligibility requirements for the program, you're entitled to benefits. And almost virtually all Medicaid programs have to fulfill the covered benefits for their covered members without limitation. Medicaid is offered to people specifically who have limited income and resources, and over 60 million adults and children are enrolled in the program. And also for Medicare, low-income beneficiaries, over 9 million of them, they can enroll in Medicaid to offer supplemental coverage for things like medication. Now, it's important in this last group to think about who on Medicare may be at risk for HIV infection. And I think we have to be broad-minded about the fact that senior citizens do have sex and may be at risk. But also, many individuals who are enrolled in Medicare enroll because they were disabled. Many of them have issues such as mental illness, long-term substance abuse problems that make them, in fact, very high risk for HIV and STDs. And we certainly see that in HIV clinics across the country. So it's important to think about the Medicare population as more than just your grandmother and lots of folks that may be able to benefit from your services. Next, please. Medicaid is administered as a federal and state partnership, and CMS operates the program, and they're required by statute to set national policies. They offer a federal match fund, the FMAP, that's based on the contribution made by each state, which is why Medicaid budgets vary so much, because some states offer a lot of resources and state revenue, and others not so much. Next, please. Now, Medicaid administration is generally undertaken at the state level within the federal guidelines, and they have a lot of latitude, as you see here, in setting eligibility, the scope and duration of services, how they'll pay for things, and they can change that within some parameters throughout the eligibility year. Next, please. As I said, eligibility is tied to specific categories of individuals, as you can see here, including individuals who have long-term disability. And there are financial requirements in terms of income that vary from state to state. Next. Now, Medicaid programs are required to cover certain benefits, as you can see here, and many of these are not specifically related to prevention services, except, as you can see towards the bottom, physician services, federally qualified health centers, rural health centers, for example, as well as laboratory services. So, for example, HIV tests themselves are covered as a lab service, and we can talk about that in a few minutes. Next. Additionally, I just want to highlight this, and this is always a controversy when I present this slide, but family planning services are also covered as a mandated required covered benefit by Medicaid programs. Now, family planning includes condoms. Condoms are used for many purposes, not only for family planning, but HIV prevention, STD prevention, and so on. And so often the question is, if a client self-identifies as being gay or bisexual, should I be offering them condoms as a family planning service because they're not planning for a family? And my answer is, offer them the condoms. How they use them, if appropriate, is really not a question in terms of Medicaid. The point is they're a covered benefit, and you should be using that benefit for Medicaid enrolled individuals so that you can stretch your condom dollars, so to speak. Additionally, at the bottom, transportation to medical care is also an offered benefit, and that's really important increasingly as we're finding clients that are just unable to access vehicles or have a hard time getting public transportation. Next, please. Now, hopefully, as many of you know, the dark blue states on the slide are the states that have expanded Medicaid through the Affordable Care Act. And as you can see, the orange states are the ones that have not. And I know that many folks feel that it's likely that nothing pretty exciting is going on in those states, particularly in the southern tier related to Medicaid. But I do want to highlight, and we'll talk about this later, many of the states that you see here in orange actually have very creative and important projects that are expanding opportunities for HIV prevention and care. And we'll highlight one of those states in a few minutes. Next, please. Now, in terms of Medicaid benefits that have been impacted by the Affordable Care Act, for those states that have expanded Medicaid, they have to offer, as you can see here, alternative benefit plans, essential health benefits, as we've already reviewed in our commercial insurance discussion, as well as provide a full range of preventive services, including those A or B grade preventive services that we discussed earlier. So as you recall, the syphilis, chlamydia, HIV screening, and so on, and syphilis screening are all A and B grade. And so those are to be provided at no cost to the beneficiary, so no out-of-pocket cost. Also in expanded benefit states that are enrolling in expanded Medicaid, they're also required to offer free family planning services, as you can see here, as well as other critical things, including parity between physical and behavioral health services. Next, please. In non-expansion states, they also, as Medicaid programs, can voluntarily cover the essential health benefits that are in addition to the traditional Medicaid benefit package. And they can offer preventive services as well. And additionally, they can expand some of those services, including to folks such as those that are duly enrolled in Medicaid and Medicare. Next, please. So for those of you who are interested in finding out about the preventive services that are being offered in your state, there are some resources here, and I'm not going to dwell on this, but the bottom bullet is important. There's a lot of dynamic opportunities that are going on now related to state Medicaid coverage for community health workers that I want to bring to your attention, and we can talk about that later in the Q&A session. Next, please. I also want to point out that Medicaid can provide lots of really innovative services for HIV and STD activities that really can be authorized through waiver programs. And many of you may be familiar with some of those waiver programs that exist in your state that have been in operation for quite a while. And as you recall, that southern tier of the expanded Medicaid map showed, a number of states that are in fact perhaps not expanding Medicaid, but are seeking authorization from CMS to do innovative services. And so states such as Florida and Texas are really pushing the envelope in terms of new demonstration activities that really do offer some exciting opportunities for prevention providers. Next, please. Now, just real quickly, I think most of us are familiar with how Medicaid traditionally has paid for things through fee-for-service. And basically, you're offering and providing a service and then getting paid afterwards for those services. But increasingly, Medicaid programs are identifying and implementing a whole array of creative ways to pay for things, including prospective payment, under capitation, and a variety of other activities. There are also in some states, looking at things like accountable care organizations, where a large healthcare system will receive funds and be responsible for providing services to the beneficiaries in their community. And so we can use some of these new payment models to actually bring in community-based organizations, health departments, and others that really don't have strong third-party reimbursement systems already in place. Next, please. Additionally, I hope that you're aware that Medicaid just released last January, or January before last, a new final ruling that really offers a much different perspective on coverage for preventive services. And so in addition to those licensed practitioners, physicians, for example, you now are able to seek coverage for other organizations and provider types if a healthcare provider, such as a physician or other licensed practitioner, has recommended that the service be provided. And so in order for a state Medicaid program to move forward with this, they have to, as you can see from the bullets, define what sorts of personnel would be offering preventive services, the sorts of services they would offer, how those services would be offered, and how they would pay for them. The final rule does not define the type of personnel to be covered under this new final rule, and so it may include community health workers, health educators, also an array of other preventive service staff in your organization, the counselors that do HIV counseling and testing, for example. Now, we're not seeing very many Medicaid programs submitting a proposal and request for a change in their state plan under this final rule. And I'd really like to light a fire under prevention providers across the country to start working with the Medicaid program as well as their colleagues in other disease-specific communities to help move the dialogue and move the dial on coverage for prevention services, and we can talk about that during the question and answer phase. Next, please. Also, as you can see here, this is the mechanics for what a state has to do in order to get coverage and approval from their CMS staff. And basically, they have to come up with a program that will define their new preventive services and submit a state plan amendment. This is a very short document. It is not like a waiver application with hundreds of pages. And those are currently posted, the ones that were proposed or approved, on the CMS website. And I can tell you, because I check that every couple of weeks, there's not very many that have actually submitted and been approved at this point. And we want to increase that. Next, please. So I'm going to go over very quickly some key steps for participating in both commercial and Medicaid markets. Once again, as we mentioned earlier, we have a new guide, a written guide that will be on the Health HIV website that really goes into a lot more detail about this. Next, please. So here you can see 8 steps for contracting. This is a contracting list that comes from a document that the HIV Medicine Association published a while back, which I contributed to. And these are some basic steps, and then the guide that you see here also goes into some more detail. And we'll talk about these real quickly over the next few minutes. Next, please. So first of all, it's really important that you talk to folks in your organization about where they are with contracting with either Medicaid or commercial health insurers. It's important that you, as an HIV program, not get too far along with your efforts in this regard without checking to see, first of all, if contracts are already in place, if contracts are being negotiated, if certain insurers have been identified as not being a priority and the reasons why and so on. And so it's important to check with your mothership to make sure that you're not getting ahead. This is particularly an issue for local health departments, if you're working in large health systems, hospitals, universities, or large federally qualified health centers. Next, please. And then in terms of identifying insurance contracting opportunities, as you can see here, and we can offer more detail in our written guide, there are some basic information that's available to you that will help cut to the chase in terms of how you may identify opportunities. First of all, the American Academy of HIV Medicine and I have teamed together and have posted now for the 2nd year a list of all the qualified health plans in the country, all Medicaid plans, website addresses, as well as all Medicaid managed care organizations' website addresses. That search engine also provides you direct links to all their provider network websites, so you can go directly there to see what you need to do in order to join their networks. Also, if there are insurers that you don't see on the list that you know have a large market share in your community, each state health insurance commissioner has posted on their website all the licensed health plans in their state. And then as you can see here, there's other resources that you might want to check out. Next, please. Now, I want to use, as an example, the state of Texas as a sort of case study for identifying opportunities. And what I'm going to present is a theoretical case study, although I'm hoping, since I've talked to folks in Texas, that they've taken some of these ideas and are running with them now. But if I was not a prevention provider in Texas, for example, and I looked at the managed care contract that the Texas Health and Human Services Commission has posted on their website, I would see that any managed care organization contracting with Medicaid is actually required to provide STD and HIV prevention, screening, counseling, diagnosis, and treatment. There's very specific requirements for what services should be provided for those that are HIV infected, and the mechanisms by which they can receive health care. Next, please. And then also I see from the managed care contract that each managed care organization has to provide education on HIV and STDs. And so this is, once again, another opportunity as a prevention provider I would think about as a possibility for moving forward. Next, please. Now, also, as an example in Texas, and this sort of information is on the American Academy of HIV Medicine website, I put together a slide that compares both the managed care plans as well as the Affordable Care Act qualified health plans in Texas, and I see that there's a lot of overlap. So in developing my marketing strategy, I realized that I don't have to go to every single one of these providers, or insurers rather, individually. I can actually do marketing to them and ask to be covered both in their Medicaid as well as their qualified health plan provider networks. That will reduce my efforts in trying to win them over. If I can get one contract, then I can be covered in both networks. Next, please. Next, in terms of steps, I want to know a little bit more about those providers. I want to know what they cover, what benefits, how they're going to pay for things, who else is in their networks that I need to be working with. I also need to know about the basics around quality measurement, performance, and reporting. And the Harvard Law School Center has offered opportunities around qualified health plans to review what sorts of things they're offering in various states. Next, please. Also, it's important to note that many of the insurers, such as we saw on the Texas slide, as well as we found through putting together the database from the American Academy website, many of those insurers operate in multiple states. And so you may want to reach out to your colleagues at the state, HIV prevention and care programs in other jurisdictions, or community-based prevention programs to find out if they work in those other jurisdictions. And you might want to ask them around these areas that I showed here on the slide. Next, please. Also, once again, and I'm not going to go into detail around this because we discuss it in the written guide, we also want to know how insurers are willing to pay for our prevention services. And we found with many of the prevention activities that we've talked about that move beyond laboratory and clinical directed services, many of those services such as prevention education, outreach linkage, case finding and so on, are actually being arranged under contract that looks very similar to the one that you have for CDC or HRSA funded activities. Does not require a claims processing system. Next, please. So once again, with our Texas example, and it is a hypothetical, if I was a HIV prevention provider, I would think about how I might want to work with organizations in my community or across the state to do a few things. First of all, to identify what our target populations are going to be, such as individuals who haven't had an HIV test in the last year. We think about what we want to offer to a managed care organization that really speaks to helping them address their contract requirements, and some of those specific services are shown here. And then as a local health department, although I might not want to seek specific payment, I do want to make sure that I negotiate a relationship with the managed care plans to offer things like partner services and to make sure they're aware of the communicable disease reporting requirements in my state. Now, this sort of marketing and organization of the delivery model that's highlighted here is also gone into a lot more detail in a webinar, once again, that we did in the fall, where we came up with lots of different scenarios for what could be offered to managed care plans through Medicaid. So you may want to check that out. It's, I think, 3 or 4 states examples with different creative ways that you may want to offer your prevention services. Next, please. So once again, in our Texas example, I want to seek sort of statewide domination of the managed care plans, and the best way to initiate that is to work very closely with the state Medicaid program and the HIV STD program to make sure that there are champions as we negotiate with managed care plans. It's important in developing our market that we come in with our homework done so that we can make a case for why a managed care plan wants to contract with my organization as a provider or a whole group of HIV and STD providers across the state. And so we need to do our homework, and we need to identify our key marketing strategies before we meet with the managed care plan. Next, please. And then once again, we would sit down with them, we would present our overview and why it is that they need us so badly. And then once that first date occurs, we need to follow up perhaps with regional meetings or intensive quarterly meetings to keep the ball rolling to make sure that we get our contracts in place. And then it will be critical for, in the example of Texas, for the Medicaid program to look at the HIV and STD quality reports to make sure the plans really are meeting the requirements of their contracts, and to provide them feedback to make sure that they know the pressure is not off. Next, please. Now, how can we pay for things using our Texas model? Well, once again, I want to make sure for many of you that do not have the ability to submit automated claims to a managed care plan or to the Medicaid fee-for-service plan, that we want to avoid that if we can. And often, as I said, that could be handled through a contract that would offer a certain package of prevention services for a defined number of folks in a service area that a managed care plan would be identifying. And so once again, that's very similar to the contracts and the grants that you receive from CDC and HRSA. Now, we need to make sure, though, that when we're entering into these agreements that we can really make good on our ability to say that, in fact, we can meet the needs of lots and lots of clients across a service area. So we need to be very careful about not overselling ourselves if we don't have that capacity. Next, please. Now, I just want to highlight a few resources that will be available this week. Next, please. First of all, many of you have asked specifically for the code set for HIV services. In the next two slides, you'll see here both HIV testing and screening slides, as well as other related slides. I do want to point out one challenge that we're encountering across the country. Generally, Medicaid programs, as well as other insurers, require an ordering provider, ordering clinician to actually require or prescribe the service be offered to a covered beneficiary. In rapid testing and point-of-care testing out in the community, as you well know, there's not a lot of clinicians that are there in the venue-based test event, in a health fair, on the testing bus, in the bar, and so on. And so we're finding that Medicaid programs and commercial insurers are not interested and will not cover rapid tests unless an ordering clinician is in the picture. Now, some folks have suggested that standing orders might be used and so on. And so this is an area that some of us are working really hard with some state Medicaid programs as an example to get them moving. Also, we're finding that home test kits, because a provider is not in the equation, are commonly not covered by health insurers and would be an out-of-pocket expense. Once again, some of us are working to push the envelope on this and to work with Medicaid programs so that they understand that home-based testing, for which the test results are reported to Medicaid and the state for positive tests, actually do offer an important way of expanding testing opportunities. I do want to mention before we move through the code sets that once again, Health HIV will be publishing a contracting guide with the how-tos of contracting. A second document is a report summarizing the findings of a 10-state assessment of coverage in Medicaid for prevention, testing, and care services. We've included specific language from Medicaid contracts from those 10 states that will help you to use an advocacy in your jurisdiction so that you can go to your Medicaid programs with examples in hand of how other states have actually incorporated HIV and STD prevention and care services in their contract requirements. And then finally, the third of the triplet of resources that will be available is a glossary that really brings you up to speed on all the health insurance terminology that you need to know so that when you're making your marketing pitch, you can speak with authority in a language that health insurers understand. So let's move on to the next slide. As I mentioned, preventive services are to be required by qualified health plans and Medicaid programs that have expanded services or expanded Medicaid enrollment. And some of those, quote, preventive medicine counseling services are already codified in procedure codes. And as you can see here, these are already in place. And what we need to do is make sure the insurers are interested in covering the sort of non-traditional, non-clinical provider to actually offer those services. Also, for those of you who are interested in expanding your condom resources, there are what's called HCPCS codes, and if you look this up in your Medicaid website in terms of covered services, you'll find the actual number of condoms that can be authorized for your clients. And each state commonly offers male and female condoms, although we did find in the 10-state study a few states did not offer coverage for female condoms. Next, please. So now we're going to open it up to questions. Michael, do you want to take it away?
Okay. Hello, everyone. Julia, we have thank you very much for your oversight of this project and moving contracting with Medicaid forward in a number of different jurisdictions and avenues. We really do appreciate that discussion you've had today with us. We do have a number of questions that are in the queue currently. And one of the questions when you were talking about essential community providers and organizations becoming essential community providers was, can an emergency department be considered an essential community provider?
Well, that's a really interesting question that no one's ever asked me, and I would suggest, and I can certainly research this and we can post the Q&A on the Health HIV website, but I would imagine that the emergency department itself alone would not be identified in an essential community provider. The hospital system in which it operates would probably need to come in and apply for that definition. And I'd have to research that a little bit because I'm a little skeptical about that possibility. But if it is in fact the case, I can offer in the response on the website some examples of other hospitals that have been included in the list.
Thank you. Another question that has emerged is HIV screening only covered annually as a routine screening? What if a second or third test is performed during the year? Is it covered if routine? Is it covered if risk-based and or medically necessary? Is repeated testing covered during pregnancy? So a bunch of different questions related to testing.
Right. Well, let's address the pregnancy issue first. And this varies because, you know, many states, in fact, are not Medicaid expansion, and so they're covering screening in a variety of different ways. But generally, if a healthcare provider, the clinician in this example, would determine that it is a medical necessity because of information that he or she would have to indicate that it's likely that they are at high risk, I don't see how an insurer could indicate a refusal to pay for the test if the clinician, in fact, has information that they've documented that the individual may require more frequent testing. The Affordable Care Act issue really comes down to whether or not the patient has to pay a copay for subsequent multiple testing. And so it's not that it's an impediment in that situation, it's that there might be a copay that would be required.
Great, thank you. And I'm assuming that, would that be the same for TB screening, which was another question that emerged?
Well, I can tell you I'm not a TB expert, but I do know a lot about health insurance. And once again, I would think that if a provider has identified the essential component, which is that they perceive them to be at risk due to exposure, that they could go ahead and do screening. Now, you know, tuberculosis screening is moving quickly in terms of technology, and the sort of traditional skin test, as we found out in the HIV care world, is not actually yielding the full cycle of TB screening that needs to go on. And so many folks are moving on to newer technology that's much more expensive. And so for those of you who are doing TB screening, particularly the health departments on the phone, I would hope and suspect that you've already checked to see whether or not both Medicaid as well as any commercial insurers you participate in are willing to pay for more expensive testing modalities, or if they're really only allowing payment for the traditional test modality.
Great, thank you. A question regarding risk reduction counseling and reimbursement. The question is related to HIV testing and persons on PrEP, and the idea that they must participate in risk reduction counseling every 3 months. Is that something that's being reimbursed, risk reduction counseling?
Well, this is where our exciting new cutting-edge HIV-related activities across the country are moving much faster than most health insurance plans are able to keep pace. And, you know, the whole issue about counseling for many preventive services often comes down to whether or not the person that's doing the counseling is licensed and can be credentialed by the health insurer to actually render the service. And so the practical side of me would say that if the individual offering the service is a licensed mental health provider, right off the bat, I would suggest that they probably could be covered for counseling services as a behavioral health service. Where we're running into barriers are for all the other folks that are actually doing PrEP support, education, so on, who are not licensed as any kind of healthcare provider and seeking coverage. And that's where, for example, with Medicaid, it's important for us to start engaging the state Medicaid programs in allowing coverage for preventive counseling services for other non-licensed personnel. And so we really need to start working in all the states that have not offered a state plan amendment to cover those services. I think that if we can demonstrate through Medicaid that the PrEP strategy works well and is cost-effective with these non-licensed personnel, then many commercial insurers who are operating in what are perceived to be high-risk markets, and I think we can all guess what they would perceive to be high risk, I would imagine that they would start to see some real opportunities there for risk reduction and also ensuring that PrEP and its full complement of services is offered effectively.
Great. There has been several questions that have emerged around the family planning and condom distribution. And I wanted to know if you could elaborate a little bit more on that, specifically on how that would work in the distribution of condoms through this reimbursement system, and are there any kind of specific numbers that will be allowed by insurers?
First of all, condoms are considered a medical supply, just as all sorts of other things our imaginations can come up with. And so as you'll see, if you look up those procedure codes in your Medicaid website that illustrates all the covered benefits and what the supply is for that activity or that product, it is likely to vary from state to state. I have looked up a couple of states, for example, and the supply amount is pretty generous, 3-month supply and a fairly large number of condoms per month, and it ranges considerably. But essentially what would happen is that a healthcare provider would write a prescription, such as they would for other medical supplies. I would take that prescription and go to, you name the pharmacy, the grocery store, or other place that has a over-the-counter kiosk that would allow us to purchase as a Medicaid beneficiary, for example. I would hand them my box, I would hand them my Medicaid card and my prescription, and I would get my box of condoms, both female or male, depending on what my interests are. And so it is very much consistent with how we would pay in Medicaid, for example, for any other medical supply or medical item. And so it should be pretty straightforward. Now, many of you health departments, for example, that are on the phone have family planning programs that are actually operating in your agencies. And once again, they can prescribe and dispense condoms directly at point of service in the health department, as an example, because they have an ordering provider who has indicated that that person should be receiving that service.
Terrific. The other question that was asked about insurers and rates in particular was that, is there a resource or a location where individuals can learn at what rates insurers within the ACA are denying services or claims?
Well, I'm not familiar with a national resource that's generally producing this information. There are several HIV advocacy groups that have put information together that are also seeking information from consumers and providers where health plans have denied covered benefits or are otherwise generally making clients' lives nuts because they're refusing to cover services. The HIVHealthReform.org website has information about how to submit information related to problems that people are encountering. And it's my understanding they're also providing feedback in this arena. Similarly, the AIDS Institute, which is there are two AIDS institutes, not the New York AIDS Institute, but the AIDS Institute, is also working in this area and have actually filed a number of rounds of litigation and inquiries to state Medicaid programs around some of these issues as well.
Great. There's been a number of questions around the guides and the slide set for today. They will both be available. The guide is currently available at the website address that I have put on the screen for you right now. The other documents will be made available on the healthhiv.org website later this afternoon once the recording becomes available. So all of that will be available for download and access for individuals on the healthhiv.org website. Julia also did mention two other publications that will be available that people are asking for. One is the glossary of health insurance terminology. That will also be available on the healthhiv.org website later today. There is a guide related to an assessment of 10 states and their HIV prevention and care programming. That will be available later this week on the healthhiv.org website as well. We do have a couple of additional questions. A really interesting perspective that has come in was regarding HCV screening and hepatitis B and A vaccinations. There wasn't much talk of them in the presentation today, and if you were providing hepatitis B and A vaccinations for MSM, would these be considered a preventative service?
Yes. And I can tell you that in many HIV clinics, for example, across the country, I see routine vaccinations provided on a regular basis to insured populations, and I'm unaware that they're having challenge around that in terms of coverage.
Great. Another kind of a policy question that is emerging, kind of foreshadowing potential future challenges. Is there any concern that as reimbursement proceeds, that one will not be able to access preventative services if they don't use their insurance or do not have insurance?
Well, I would say that that's probably a question to ask CDC to address. I know that some jurisdictions have told their funded agencies that they need to seek reimbursement for services that were traditionally covered under their CDC funding, but I don't work for the federal government, so I really can't speak on their behalf, and I don't know how clear their crystal balls are related to what's coming up in the future.
Thank you, Julia. We do have a whole slew of other questions that are emerging. for us, then we can kind of group these questions and provide answers for them on our website. Two things I did want to point out. There was some questions about ICD-9 coding and maximizing third-party reimbursement. HealthHIV does have available on our website a publication called Maximizing Third-Party Reimbursement through Enhanced Medical Documentation and Coding. There is also a 4-part webinar series that is dedicated to this process that you may wish to access. And you can access that through the healthhiv.org website. We will be we're in the process of constructing right now an ICD-10 presentation regarding the ICD-10 implementation in October of this year. Another question is regarding the non-medical doctors providing services. As a non-MD, providers who are brought into the mix, I'm sorry, let me read this again. As non-MD providers are brought into the mix of who can provide services, will there be an increase in requirements such as an MSW or being a licensed professional? How will peer leaders be able to bill if they are paraprofessional?
Well, this is the important question that we're trying to address with many states around coverage for non-licensed personnel to offer what we would perceive as really important preventive services. And this is why it's very important for us to be talking as a group, not individually, with state Medicaid programs around their plans to submit state plan amendments so that non-licensed personnel can actually offer those services and be compensated under the usual payment mechanism. It's very important to note, however, that many Medicaid programs actually cover non-licensed personnel in a variety of different ways and for a variety of different services. So, for example, New Mexico has embedded in their managed care organizations' contracts compensation requirements for community health workers, including Prometeras. And similarly, in other jurisdictions, community health workers are covered in a variety of different ways, including requirements that the managed care plans use some of their administrative fees to pay for those individual types of personnel. Now, also, I mean, that's sort of the stick. On the carrot end of things, we're finding that many managed care plans are very interested in working with community-based organizations and other types of providers that already know how to do things like community outreach, that are willing and able to go out in the community and identify beneficiaries and help them get back into care or to actually use services in a more preventive activity rather than going to the emergency room, for example. And so I've been working with health plans across the country that are very interested in understanding what organizations have to offer in those communities they're not familiar with or they're not experienced with. And so I would suggest that there may be real opportunities. That would require a standard contract once again, where you would be committed to providing services as defined under the contract to do outreach, medical case management, preventive education services, HIV or other screening services to a defined population. So there are opportunities out there that don't require the Medicaid program to speed along and submit something to CMS. There are lots of things going on across the country already in place because the plans are very interested in reducing unnecessary utilization and expenditures and normalizing healthcare utilization in a more preventive model.
Thank you, Julia. I do have a lot of additional questions that what we will do is we will group those questions and categorize them, and we will post them on our website with some answers to those questions over the next 24 to 48 hours. But Julia, I do want to thank you for being with us today and for providing this information to over 350 individuals who participated today in the program. I do want to alert you to 2 upcoming Health HIV webinars again. The first is related to our Leadership Link and Learn webinar series as part of our ASO Leadership Initiative. What is Leadership in Healthcare Today, which is going to be offered on March the 18th at 1 p.m., as well as an upcoming webinar being hosted by the National Coalition for LGBT Health, Time for Trusting Relationships, LGBT Health Awareness Week, which is going to be occurring on March 25th at 4 p.m. I do encourage you to please either email your questions to us today. If you did not get a chance to post your question in the chat box today, I have displayed on the screen for you Health HIV's capacity building programs and how to access capacity building through Health HIV's 3D program and its National Center for Healthcare Capacity Building. You can contact Marissa Tonelli, our Senior Capacity Building Manager, at marissa@healthhiv.org. If you did not get a chance to have your question answered today, I will be pulling the questions from the chat box, and we will kindly ask Julia if she could help prepare responses to those questions today. And as the webinar comes to a close, and you did not get your question into the chat box, please send Marissa an email, and we will add that to our question list. Again, our webinar will be posted on the Health HIV website later today. It will be available along with the recording, the slide set, and the contracting guide. So please feel free to visit our website by COB today, and we will have that information available to you. Over the next 48 hours, we will get a list of the questions and answers to those questions available. I do also encourage you to please complete the survey at the end of the presentation today, as it's very important for us to get your feedback on the quality and applicability of the information being presented today to your programs and services. At this time, I'd like to thank you for taking part in Health HIV's webinar series and our 3D HIV prevention programming, and we look forward to seeing you on a future webinar in the future. Thank you.